So good morning, everyone. Thank you so much for being here with us today. We will be talking about rural health innovation, continuing the conversation which has started in January. Just a few house rules. We are recording this session just so that you are aware, and we probably will share the recording with you afterwards. Please make sure your mic is muted throughout the duration of the presentation if you're not speaking or asking a question. And we will have 3 Q&A sessions. So during these times, we ask that you use the raise the hand feature or put your message in the chat so that we can facilitate this better. And now if Jim could take it away with a bit of an introduction of what this session will look like, please.
Thanks, Bruna. Thank you, everybody, for coming. And we're very pleased to be having the second workshop and really looking forward to digging in and getting some work going. I'm the academic director of the Dunin-Deshpande Queen's Innovation Center, which is championing innovation and entrepreneurship, both across the Queen's community, but importantly across the region. And we're also a partner in the Health Innovation YGK initiative, which was the federally funded program to try to bring together different people working in the health innovation space in the region. So the purpose of this meeting really is to provide an opportunity both to get perspectives. We're very pleased that David is going to share some ideas and thoughts that he has about access to health and health in the rural region, and also we're very much hoping it's going to provide a basis for conversation. So we're really pleased to see so many people sign up, and really looking forward to hearing your thoughts. Tracy Snow is going to be the moderator for this, and she did an excellent job last time with the first of these. So very much looking forward to how that goes. From the Innovation Center's perspective, what we're trying to do and what we're interested in doing is trying to help participate and support conversations to identify themes that come out, better understand the kinds of things that are the initiatives that are underway already, but very much help support what we hope will be embedded solutions that are, by different parts of the region, from different parts of the region, and then helping to support in the ways that we can. So I'd just like to keep that in mind as we have this conversation. I think really what we're hoping is that by talking about these different issues and seeing the work that's being done, that we'll be able to identify some themes, and then we can go to next steps and identify groups of people interested in getting something going, and that's where we can help as well. So without further ado, welcome very much to this workshop. I hope that you find it helpful. And I'm going to hand over to Tracy.
Just before I introduce Tracy, to start us off, to get to know the audience, we are going to be launching a Zoom poll. You all should see it right now. These are all anonymous questions, so we will not see who has answered what, but we just want to get to know you a little bit better. And we will share these results with you afterwards, so just so that we can understand the perspective that we have from the people that are attending this meeting. So while you do that, I will start by introducing our moderator, Tracy Snow. She is the Rural Economic and Community Development Manager. And so she was recently appointed this for the City of Kingston. And so she's responsible for overseeing all city-led rural economic development initiatives, leading the implementation of new rural economic development strategy and collaborating with businesses and residents. Besides this, Tracy is an entrepreneurial leader, communicator, and connective, and she has extensive knowledge as a business owner. Additionally, she worked for the County of Lennox and Addington for over 11 years. And her last role was as Senior Economic Development Officer. So please take it away, Tracy.
Good morning, everybody. I was going to say good afternoon. Thank you so much for attending our second session. And we're doing this a little differently this time. The last time we had a panel of quite a number of people from various roles in rural health. And this time we're doing more of a fireside one-on-one chat, and absolutely excited to be inviting you to be engaged as well. At some point, we'll let you know and hear your thoughts and answer some of the questions to support some of the questions and ideas that you may have with regards to rural health and the gaps and opportunities that we're trying to address with rural health. I'm now going to be introducing to David Townsend, the Executive Director of South Frontenac Community Services since 2010. And I'll let David do his introduction and little bio, and then we'll go from there.
Sure, thanks, Tracy. So as Tracy said, I've been out here, as I like to jokingly say, 12 and a half years into a 6-month contract, working in a healthcare setting and community support services. So our job is to really keep seniors as healthy as they can in their own homes as long as they can, and try to keep healthcare costs down, because it's a lot more affordable to keep somebody involved with CSS than it is either in long-term care or moving into an ALC, alternative level of care bed in the hospital. I'm getting closer to retirement and looking forward to that, but I've been very involved in healthcare in Southeast Ontario for the last I'll call it almost 18 plus years.
Wonderful. Thank you so much. So I actually just have an opening question for you before we do the PowerPoint presentation. And I wanted to know, what does rural health mean to you, David?
Rural health means that the services that somebody needs or the healthcare that somebody needs is available to them, preferably locally. You know, for a lot of people, especially older adults, the ability to travel is becoming less easy, and it's becoming more cost prohibitive in today's world to, travel to healthcare. So how can we bring healthcare to you where you live?
Thank you. And this is why we're here. So very appreciative. I'm going to let you then proceed, David, with your PowerPoint, and we'll stop kind of halfway through and allow questions and discussion, and then we'll continue that on after.
Sure. So welcome. So healthcare in a rural setting. There were 5 topics that came out on January 19th. One was lack of access to care. Second one was housing. Third one was communications. Fourth was transportation. And 5 is funding. And the ones I really want to talk about today are number 1 and number 3. And that's what we'll focus on with where I think we can go in dealing with rural innovation and rural healthcare. So our focus today is how to improve access to care, how to address barriers and breakdowns. And my takeaway thought is really how to change healthcare conversation from hospital care to healthcare that's in the right place at the right time by the right providers. I thought I might want to talk about funding, but I didn't want to ask you all to write a check in support of my agency today. So no funding conversations whatsoever, please. So the new initiatives that I want to talk about today. One is the health home that's being created by our Ontario health teams. And the second one is our compassionate communities being led locally by CCK, and I see Florence Campbell has joined us on the call. So that's wonderful. But those are the 2 that I really want to focus on. The first one, before we get to the Q&A, is the health home. I'm going to talk a little bit about the province's quadruple aim, what Dr. Kim Morrison is doing in creating a health neighborhood, and where we really want to end up with changing our healthcare system and building a healthcare system that really hasn't existed before. So the quadruple aim is the provincial gobbledygook, if you want. This is how they created Ontario health teams. Megan, if we can get the next one, there it is. So the province wants to focus on the patient experience. Is it a positive one? They want to focus on population health. Understand that over 90% of our provincial population has a physician, but less than 10% of our population ends up in hospitals. So we need to change the focus on the population health. Thirdly, the reducing costs. As we've all heard time and again, the healthcare budget is the most expensive part of our tax base and where the government spends dollars. Projections are that it's going to continue to increase. So how do we change the system to reduce the costs? And finally, we really need to look after the people in healthcare. So those who are delivering, it's been great for 2 years, all the platitudes and all the thanks for healthcare workers managing COVID well, but there's a lot of burnout and there's not a lot of young people coming into healthcare. So how do we look after the people? The health home is best described by being a house. You can sort of see what they're talking of with the development, the functions, and the foundations. But I'll talk a little bit more specifically because that's very, very high level of what we're trying to do here in Frontenac, Lennox, and Addington. So Dr. Kim Morrison is the lead of our Ontario health team, and she's talking of the health neighborhood, which is the next slide, Megan. And it involves all of these players coming together and actually learning how to communicate with each other, how to talk to each other, how to ensure that when somebody's finished with my services here at Southern Frontenac Community Services, I just don't wave and say bye. How do I make sure that you're linked properly with the next stage or the next group within the health home to make sure that you don't have to tell your story many times, you don't fall through the cracks, you go, I don't really want to pick up the phone and call somebody because I don't know them. It's my job in CSS to make sure that we do that. So this is what the health neighborhood is all about. And then we're talking about the health home. Okay, and at the center of healthcare cannot be a provider. It has to be a person. So the center of healthcare is you. You know your needs. You may not understand them, but if you want to stay healthy, you've got to be able to get the supports you need to do that. Around you is making sure that you've got the proper caregivers, you've got family involved. Healthcare isn't an individual thing, it really is a group effort. And then the people-centered healthcare home brings in some of the medical people. So it brings in some of the behaviorists. So diabetes education, your general practitioner, family health teams and everything are now branching into practical nursing. But these are the people that you're going to interact with in a health home more often than you would with an agency like mine or a hospital or a community health center or whatever else it might be. So this is the entire focus of what a health home is meant to do. The community-based care grows another level. This is where community comes in. So agencies like this one, you're going to have medical specialists, those that are going to look after your knees or your hips or things that, will keep you going. You've got community nurses, being able to come out and still do infant and baby care. You've got, the pharmacist and everybody else that really knows your story. And this is what we're trying to bring all of these people together to talk to each other for the very first time. So very seldom have pharmacists, other than, taking a prescription, talk to a physician, even though they see that, the meds that you're on may be having an impact or something else. And we're trying to really focus on improving the communication. The next slide talks about the hospital-based care. It's at the very back end. This is where care at the home or pharmacy or meds or physician really need true expertise. And we're very lucky to have The 3 hospitals in Frontenac, Lennox, and Addington that we do, because they're all great places, but they need to be in a position to support the person at the very front and not the other way around. And that's a change that the Ontario Health Team is trying very hard to make with the health home creation. So how do you bring all of these people together? It really talks of an integrated care team. So here are 3 different slides that sort of say, you know what, I'm typically healthy. I've got a bit of a flu bug, nothing else going on. The picture on the left is just, I'm going to talk to my family who are going to say, David, don't be a man, go to the doctor. See if you can get some help, some direction that's going to look after that illness for you. The doc may look at it and go, you know what, I think you need a bit more help. I think you're sick because you're not getting fed properly. So can I connect you with a Meals on Wheels program that's going to get the right nutrition for you? Or they may sort of say, you're not active enough, your feet are suffering, which is why you can't get active. I know of a foot care program that's available that'll help get your feet back in a shape where you can do something about it. So the doctor's really helping the person focus on what they need to do to regain their health and everything else. And then the final slide out there is that if the community can't handle it, the physician can't, they then bring in the specialists and they bring in the hospitals. So that's what the health home in a nutshell is all about. And I would love to open it up for any questions, any concerns. And as I'm part of the Ontario Health Team group that's building it, the OHT leadership team, if there are things that I can take from this audience back to that team, I would gladly do so. And I'm glad to see Alan Katz on the call too, because he's also part of that. So love to open it up for questions, Tracy.
Yeah, so this is where you as the audience get to get engaged. If you can please use the chat and let us know if you're interested, or put your hand up. I believe in the reactions section, there's an opportunity to raise a hand. We would be very happy to answer any questions, or if you have any thoughts or ideas, then we would be pleased to be part of that as well. We're going to allot about 7 or 8 minutes for this piece until we continue with the PowerPoint. Anybody have any questions? Oh, Alan Katz. Alan?
Good morning. David,
Morning.
Great presentation. Thank you so much for introducing the concept of the Ontario Health Team, which is still relatively new, and even newer, the concept of the health home, which is meant to be the first stop, the primary care, first contact within the community. So it could be a sole charge physician's office, it could be a family health team, it could be a family health group, it could be an independent nurse practitioner's office, it could be a community health center, it could be all those things. And we're just trying to get away from having, the 3-letter acronyms of the FITS and the FIGs and the FOs and all those other things, and just make it simple and call it the place where you seek your first level of contact with the healthcare system. I also really appreciated the various levels of care as you've demonstrated on your slide. We also want to emphasize the fact that mental health is an exceptionally important component of the Ontario Health Team and the health homes, as well as many of the exceptional services and programs you and your colleagues in the community support sector provide in the area of socialization, food services, transportation services, to avoid the social isolation that may exist, not just in urban settings, but predominantly in rural settings as well. So that little nuance, which may not have leaped off the page in your PowerPoint presentation, needs to be emphasized. I just wanted to add that there, but thanks, great presentation. And, when it comes to the health home, I basically just carry Glenn Brown's bags around. Glenn is the physician from Napanee. He used to be appointed and was chair of the Department of Family Medicine at Queen's for many, many years. And he is leading the Health Home Initiative, and I'm just supporting him as co-chair.
Wonderful. Thank you very much, Alan, for your comments. We appreciate it. Any other thoughts, comments on that first part of the presentation?
Maybe I can ask a question if that's okay, Tracy.
Yes, please.
So David, I really enjoyed your talk, and I really like the way you've laid out the sort of patient-centric health home piece. I just wonder if you had any thoughts to, what, if we, go to the different parts of, say, Frontenac County, for example, so South Central and North Frontenac, just, what sort of similarities or differences you might imagine you might see in a health home kind of a model, or what themes might emerge in that?
Oh, I'm
put you on the spot. Sorry.
No, it's a great question. Because one of the biggest issues in a rural community, and I think Meredith and Louise brought this up at the last time, is that the geography is so vast and the media is so little that unless you really know your community, you have no idea where to start looking. We're fortunate in a way is that we've got family physicians in Sharbot Lake and in Sydenham, and then over in Lennox and Addington, we've got the 2 community support agencies, Rural Frontenac, Community Services in Sharbot Lake, and my agency based here in the South. But again, I'm focusing on community. So if you're not in Sharbot Lake or Sydenham, do you really know where to go to get the care that you need? And that communication piece, I really have no idea how to address and find. Jim, I guess it's a challenge that somehow we have to figure out how to.
Sounds like David might have frozen temporarily. Tracy, if I might be so bold, maybe I just put that. Oh, sorry, David, you're back again. Just see if anybody else from say Central or North Frontenac had any thoughts about health home that maybe they'd like to contribute. Sorry, David, I just stepped in when you froze there.
And we also have a comment from Frank in the chat box as well that talks about a situation that he experienced with a rural resident trying to get information with telehealth and the connectivity piece. So one of the things that we are waiting very desperately for from the province and from actually a communications partner is that there is going to be a public announcement fairly shortly with connectivity, high-speed internet access for our rural communities. So Frontenac, Lennox, Addington, rural Kingston as well. So that actually information should be coming shortly. The province has been announcing the connectivity piece and the expansion of broadband and high-speed internet in various regions across the province. And we're honestly just waiting for that to happen here. It will happen. It's just a matter of time before they announce it and what that looks like. So I hope, Frank, that answers your question. Or was it a connectivity problem with telehealth itself? I guess I'm not sure if that was your question.
He said internet problem, not telehealth.
Okay, perfect. Okay.
Not bandwidth. So you can imagine too, especially if it was a video kind of thing, that would be all the more problematic.
Yeah, so there will be a provincial announcement. We were hoping a month ago, but it will be coming shortly down the pipeline that will talk to broadband and high-speed internet for rural communities. So that will absolutely be a game changer for much of this and for some of the opportunities that we could be putting together to support rural communities and health. Any other comments before we go to the next part of the PowerPoint? I think we're good. So David, do you want to continue on then with the rest of the PowerPoint? Oh, you're on mute. Can't hear you.
Tracy, there's a quick question from Christina in the chat.
Yeah, are referring to regional rural broadband project. Sorry, I'm not sure if that's how it's defined, Christina, but there is an announcement with the province and a communications partner to support rural broadband and internet. I don't know if that's what they're calling it, but it will allow money to be brought into the region, and with this communications partner to build opportunities for broadband and high-speed internet in the places that we're just not currently having success. I hope that answer. I think it's run out of Guelph for the province. Sorry, I'm not sure. I apologize.
And Scott Taylor has his hand up here.
Go ahead, Scott.
Thank you. Yeah, I'm Scott Taylor. I'm the director at Extender Family Kingston. We have a day supports program here, but also part of the Developmental Services Ontario. My colleague, my manager, actually Megan Taylor, is on the call as well. But I was really intrigued to come on to see the presentation, and it's great so far. Thank you. But I think I wanted to share just in relation to the last comment around connectivity and the challenges that presents. For us as a day supports program, when COVID hit, we had to close our day support program down like many other organisations, and obviously prevented us giving the supports that we needed. But we transitioned very quickly to a virtual platform using Zoom, and ever since we've been doing 2 sessions a day ever since COVID, kind of within the first couple of weeks of COVID, the pandemic starting. But in addition to that, what we were finding was connectivity issues. We had some individuals that didn't have access to technology, the connectivity they required. So we did actually launch our own internal lending library, one for the tools that people need, for instance, the equipment. We have specific terminals that are 27-inch touchscreens that are exclusively used for Zoom only, so they don't have any issues with Microsoft updates or viruses or anything like that. And we have a pool of 12 of those units available. But in addition, we worked with Bell to purchase a mobile internet hub, which it's not guaranteed that it works everywhere. But the tests that we've had done, and we supply that with the Zoom unit for our assessors to be able to perform assessments, but also for the individuals to join our Zoom sessions and be part of the supports that were available through the pandemic. So outside of the bigger projects where obviously we're all waiting for connectivity, and me being one, I live in a rural setting and the connectivity is terrible. I did try this unit, increase my speeds by 60 times. So these units are very cheap to purchase and maintain. So just outside of waiting for the big companies to install this, there are some other options to explore, and availability to allow people to be able to connect and access services we do it on a lending basis, but I'm very happy to share more information on that if you'd like.
Thank you. Yeah, that would be really appreciative. David, did you have any thoughts on that?
I just really want to start by giving a shout out to the Kingston Frontenac Public Library, who have installed several hotspot places throughout Frontenac County. I do know that they have a lending library of tablets for technology. I also want to state that both Rural Frontenac Community Services and this agency have tablets that we lend out. Our library is about 30 tablets strong right now. So and then we've backed that up by recruiting a volunteer team that is willing to go out and train the seniors on how to use the tablets so that they can connect best. But Scott, the connectivity in the rural community is I'll call it miss and hit. If you're in a village like Sydenham, you're pretty darn good, but you live 3 kilometers out and there's a hill in between, you're in trouble. And that's the further north you get, the worse it gets.
Absolutely.
Just looking at the notes, making sure we're covering everybody. Thank you, Amir, for your thoughts on Hong Kong and the 5G. Appreciate that. Okay, David, is there anything else on that? We're going to continue with the PowerPoint, and then we'll have lots of opportunity for more questions as well. Okay, David, do you want to continue with that, the rest of the presentation?
Sure can. Megan, if you'd like to bring it up. Perfect. So the next new idea that we've got, or innovative idea that we've got, is with thanks to Florence Campbell and her drive and desire, is we're creating compassionate communities. And we're actually launching a 2-year pilot project now for this year, and sort of in the second year to come. That's going to figure out how we can connect people, especially in a rural community, to health supports, mental health supports, food supports, whatever they need, so that it becomes a lot less of a guessing game. And it really takes a community to look after everybody. So what Florence has helped us do is she's brought over the model that Dr. Kingston in Mendip, England created. And I've got some neat ideas on it, but Mendip is the town that really found the cure to loneliness. And their vision was they wanted to create a community where people are supported to be creative, active, and resourceful in response to their own and each other's unique and shared needs, with easily accessible care and support available to all. And that's what a compassionate community does. It brings back the fact that you can walk down the street and you're going to talk to people, and you're going to know your neighbor needs help, and you're going to reach out. And part of the project is going to be finding and recruiting what we will call community connectors, who really have a wealth of information that they have at their fingertips that they can share. So the impact from the Frome model. They've done some data, that's gotten the National Health Service to support it, but compassionate communities is spreading worldwide. We're not, the first. We may be the first in Canada, but there's a lot of other countries like Australia that have already adopted compassionate communities. And during the stat period that I can share in front of you, you can sort of see how many people actively came on as a volunteer community connector, okay? How many people they saw, but the percentage of people that really responded in a very positive way to compassionate communities, and how many of them said their health or their well-being, whether it's a physical health, a mental health, or a social isolation health, actually improved. There's also a financial impact on compassionate communities. And if our Ontario government through Ontario Health Teams is looking to get a better bang for their dollars, here's a great example that we need them to do it. So the economic impact is the 17% decrease in emergency visits. Okay. At the same time, emergency visits are going up. We look at our healthcare here in Frontenac, Lennox, and Addington, and if it's 8 o'clock at night and you have a health problem, where are you going to go? To the emergency room. Okay. Is it something that the emergency room needs to see you about? Not necessarily. So how do we connect you better to get you the supports that are going to really improve your healthcare, but also reduce costs? So talk a little bit about the potential model that we're going to be putting into place here in Frontenac, Lennox, and Addington. And I'm thrilled that we've bounced around a little bit, but we have settled on South Frontenac, really taking the lead on a potential model. Our Rural Kingston Family Health Organization, Meredith Pricker was on our last call. She's part of that team. But they're the ones who are going to be taking the physician lead. Our agency here in Southern Frontenac is also going to be a partner with it. And we're very fortunate, as you're going to see, that we've got some huge partners with the Canadian Frailty Network and otherwise. So Megan, the compassionate communities, the goal is to change 2 social norms to create a more inclusive community. So that's what the goal of our project is. And then the next slide really talks of who's getting involved. So the Rural Kingston community members, Okay, we are going to busily recruit approximately 30 community connectors. So these are people who are given information, but they know who the other healthcare providers are, and whether healthcare is food or physical doesn't really matter. But these people are going to be identified as knowing what's available in our community. And then the Canadian Frailty Network has really agreed to take on the lead community connector. They're going to look after obtaining funding. They're going to look after the database. They're going to do the research. They're going to, provide the reports that are necessary. And then the CCKC is the Compassionate Communities Kingston, Canada. And they're going to really make sure that we're following the model as closely as we can so we can evaluate it. The next slide talks about the pilot project roles, and it talks of what each group is really trying to do. And the CC hub is what's happening here on the ground with the agencies that are getting involved in South Frontenac. So the signposting is the communication piece, the feedback, the new resources, but most importantly, the volunteers to help lead the activities. I actually have a staff person who's being assigned to the role so that we can maintain some real accountability. And if there's a breakdown, I've got somebody who can jump into us. So the proposed timeline for compassionate communities, we're in phase 1 right now. We are recruiting volunteers. We are building a database that is not just healthcare, it's not just food, but it's where do people go in our community, and where they go, it could be like, the greenhouse in Sunbury, or it could be, Daryl Silver's down on Rutledge Road here in South Frontenac. Where people go is where they're going to get their information. So how do we get non-healthcare providers involved and willing to share the resources that are coming? And then phase 2 is what will be taking place next year. And phase 3 is how do we sustain this and keep it going beyond the 2 years of funding that we're hoping to have in hand very, very shortly. So the Community Connector Pilot Project, the phase 1, we've got some dates in place. We are actively recruiting volunteers. Most agencies like mine have put together databases of community partners. We're pulling all of those together to create one, and then figure out how to maintain it and keep it current and up to date. And so that's what our Compassionate Communities is trying to do. It's trying to connect people into the community. It's trying to reduce costs, but it's trying to build care in the right place at the right time. So I would welcome any questions. I know Florence is on the call, and I will try to answer them, but you may be hearing from her too.
David, I have a question first, if that's okay.
Sure.
So you had talked about pulling together volunteers and community people. What kind of partnerships do you need? Have you done some initial reach out to some organizations, groups to help support this? Is there anything, the viewers and ourselves, the City of Kingston, can do to help with this as well? So just looking for some more information.
Oh, okay. I guess, in a rural community, we're blessed with the churches. We're happy with the service clubs. Those are still some of the traditional groups that are very community focused. They will all be, receiving presentations and coming on board. We're also aware that sort of some stores have a very high traffic area, and we'll be talking with them as how do we make sure that the information we've got is available through them. So I think until we get our key volunteers in place, and we would welcome anybody to join us from that point of view. But then we'll really know where the help is going to be needed.
Okay, thank you. Is there any comments or questions from the audience? A lot of really great information. Really appreciate how you set it up and simplified it in terms of the layers that are part of health and private health, and everybody that has to be involved depending on the situation and the status of the patient or the resident. Any thoughts or comments from anybody on that second piece of the PowerPoint?
Ben Gooch from Providence Care has his hand up. Tracy.
Hi, Ben. Please go ahead.
Hey, David. Thank you so much for hosting this session. And I'll say that working with you, I realize how effective you are at canvassing for volunteers and recruiting volunteers. And it's amazing, what rural volunteers can put together. I've got two questions, I guess. One is, is this something we're looking to scale out past Southern Frontenac? And the second part of the question is, when we're better at navigating and building these communities, are we expecting that service providers might have capacity problems keeping up? Because, I think that, once the word is out that these services are available, I just want people to be able to continue to access services, and wondering if we have anything baked in terms of a plan, if that's the case. And thanks again.
Okay, well, let me start with the first question because that's easy. I think that, we've talked about scaling the project up and everything else. I think what we need to do is show a success story in a community like South Frontenac, which will then make it a lot easier to scale the project because it's local and we've seen how it's been implemented. So, Florence and the Compassionate Communities Kingston team have really, I think, been very smart in picking an area to say, let's put our efforts in, let's make sure it works, and then we can move it. As to the second one, Ben, capacity is always going to be an issue, especially with scarce health human resources in today's world. But at some point, we have to change the way healthcare has been delivered and realize that hospital care is very, very expensive. Okay. And physicians are less so. And, community support services, are sort of a lot more affordable to do. So where are you going to get the bigger bang for the buck in healthcare? So if you can deal with an issue when it's small, it's less, expensive to do. But if you wait until it blows up, it becomes very expensive. And from my perspective, we have to change the way we've delivered healthcare. I don't know if that
answer everything for you, Ben? Okay, looks like we're getting quite a few questions. Thanks, Ben, for your questions. Let's go to Helen Cooper, and then we'll continue on with everybody else's questions as well.
Yeah, first of all, congratulations to David and Florence. Happy to hear that the Froome model is, it's pronounced Froome, is it not? Is found a home, because it's extremely interesting. Just a word of caution for all of us. And our community council of the Ontario Health Team has adopted this idea. First of all, is let's not use the word patient, because what we're doing is talking about people who are not necessarily sick, or if they are, it's at a very early stage that can be much more easily dealt with prevention than cure, as David has been pointing out. And patient is such a loaded term in terms of who's the recipient and who's the deliverer. And so I do it, we all do it, but we've got to start thinking in terms of talking about people as we're much greater equity in the system is really important.
That's why I caught myself and I said resident right after. As soon as I said it and it came out of my mouth, I'm like, that's not the term. I
was trying to pick on you.
No, it's all good.
Else. Just a reminder. I mean, our mindset is so ingrained in how we look at healthcare and what's really healthcare. But as David's pointing out, healthcare is a much broader concept than services funded by the Ministry of Health.
No, absolutely. And thank you for that comment. And just a little background as well. So I've been on a couple of different hospital boards in the past, Lennox-Hampton County being one of them, and also the Trent Memorial Hospital. And then I also grew up, my mom was a nurse in a very small hospital. And so grew up literally almost in the hospital most of my young childhood. So I have a little bit of a medical background, and I do appreciate that comment. And you're right. It is residents and people first, and we're here to support them. Thank you, Helen. Any other thoughts before I go to the next person? No, I think we're good. Okay, Jim, do you want to go, and then I'll get to Deb?
It's a very quick clarification. David, I just want to make sure I understand that the Community Connector Hub, that initiative you're talking, is that across all residents of all ages, or is it primarily focused towards seniors?
I would say the focus is more on older adults, but it is not exclusive to that. It really is focusing on how do we improve healthcare for all. It really is I hate to sort of say it because I'm now one of them, but the older adults that are the biggest cost factor into healthcare.
I'm with you there, David. Don't worry. Thank you.
All good, perfect. So I think Ben McKillicum had his hand up first, and then Deb will get to you, I promise.
Awesome. Can you hear me here?
Go ahead, Ben.
Can you hear me? Perfect. Yeah, a great presentation. Thanks for having me on today. I just wanted to highlight a success story that Kingston has right on the urban boundary on Highway 15 there, a COPE outpatient clinic. It's been a great success story. I'm actually trying to get this promoted with Ontario Health. They provide a lot of the same services that Hotel 2 does, but right on that kind of urban boundary outside the hospital setting, like you said, at a fraction of the cost. So I think the model they have there would be something that's really scalable. That if you could kind of deploy in other urban boundaries where the service just seems to be great and a lot of positive feedback at a fraction of the cost. Have you guys been in contact with them at all, or are you guys aware of the clinic?
I'm aware of the clinic, but I don't think we have connected with it.
So Dr. Craig Murphy has set it up. I can share the contact information and the full breadth of outpatient services that you do at again, it's a growing expanding. So it's kind of an interesting model.
Yep.
Great, thanks, Ben. Yeah, if you want to get that information to Dave, that's wonderful. Any other comments, Ben, before I go to Deb?
Thank you.
Okay, thank you. Please go ahead, Deb.
Hi, thanks so much for having me. I'm here on behalf of the Maltby Center in Kingston, serving children and youth with mental health and autism. And so thinking of the presentation, one thought came to mind at the earlier part that where the starting point was, it was with kind of a single individual. And I just wondered how much of this is also a response to the unit and the family, understanding that, that might be different depending on the age or the population you serve. But for us, very much, it tends to be a family, a response to more than just the one. And the second part of that question was just wondering a little bit more about the actual role, if it's mainly a connector role or if there's any part of opportunities for either advocacy or mental health promotion in terms of the service that the volunteers will be providing.
I'm going to start with the second one, Deb, because I'm going to come back and sort of get you to re-question the first one. The communicate or the community connectors will have a very minor advocacy role. Like, you come into their store and you're limping badly, and I would hope that the connectors, and it's one of the things we'll be training them to do, is to go, have you seen or talked to somebody about that limp, because the last time you were in you hadn't. But for the most part, their role is going to be I know you and I know things aren't well. Can I put you in contact with, can I arrange for something to help you with whatever the malaise is currently there. So it's more that they have a broad base of knowledge and information that they will then be sharing with you, or asking some of the right questions that otherwise don't get asked in today's world. Okay. Back to the health home with the individual. We have to get to a point where you will tell your story once, and whether it's you as the person at the center or it's your family around you, we have to realize that healthcare is not just an individual problem, but it belongs to others. And there may be others within your carer group that can speak for you more forcefully or more clearly, or whatever the case might be. And we have to get to the point where we include the close people in that first connection into your healthcare and not just the one person. Does that answer?
Yes, I think that's maybe part of just even an approach to services that, who is the client or the person we're addressing, and sometimes it's more than just
correct
the one. Yeah. So thank you for your response.
Yeah.
Oh, you're muted, Tracy. So.
Thanks, Deb. Any other questions with regard to the second part of that presentation?
I had one more if I'm permitted, but if anybody else has any, I don't mind sharing.
Sure, go ahead.
Go listen to that. You can hear the enthusiasm in her voice. Just with looking at that, the Compassionate Kingston, the slide you had, our goal is to change 2 social norms, to mobilize a collaborative community culture, shift the culture from one where members instinctively decline help, and then reinforce and create a common community culture. Yeah. It's maybe a bit of a leading question. What how could we help? I'll put a sort of collective we, and do you have some sort of immediate thoughts of what could be 2 or 3 particularly sort of impactful assistances? Okay, budget I imagine is probably one on the list, but I'm just curious because I'd be very interested in your answer. I had one last thought after that. Sorry.
Yeah, it's not a leading question because I really don't have a good answer for that one. I'm still so new into this world that I would love to say to Florence, if you're still on the call, please put your hand up and jump in on this one. But it's a culture, especially with seniors, where I'm 66. For 66 years, I've been able to do it. I can't do it anymore. And it's really hard for me to turn and sort of say, I need help in getting something done. We have to see that in our community or in our culture, that's not a sign of weakness. That's actually a sign of strength. And that's where the culture shift comes in. I don't know how to make it. I don't know who can lead it. It's just, I know that's one of the changes that really, really has to come in. If there are, other ideas on how to get people involved, I don't know them yet because I'm learning as I go. So Jim, it was a great question. I wish I had a stock answer, but I don't.
Well, thanks, David. I think actually Florence is teed up, and maybe I'll let Florence speak to that. And I have one last thought, Tracy, if I might, before.
Absolutely.
But I'm going to let Florence speak instead. So.
Thank you very much for the opportunity. David's done a great job. So I'll just add a few things based on, since we started in 2017 with that goal of changing these 2 social norms. It's a long-term goal. And what we do is search for projects that will help us meet those goals. For example, one of the projects that we've been engaged in for 4 years, and we've trained about 350 citizens, is advanced care planning. And advanced care planning is all about conversations. We don't want to talk about death and dying, but we're getting people to engage in these conversations and make plans. So one thing you could do is to encourage anybody you can to get an advanced care plan. 80% of Canadians feel we should have a plan, and about 20% of us do. So we have a long way to go. But it's a concrete project that gets conversations going and sharing of information and sharing of support. And then David talked a lot about the community connector role. That's going to be another way, and we'll want to engage as many citizens we get. Anybody and everybody can be a community connector. The main job is to signpost. And where we're at with that is we've had 2 or 3 training sessions, and we had a session in early March, and there were 2 people from South Frontenac at the session, about 12 people, as a little pilot to and this group of 12 is very enthusiastic about being community connectors, and they have homework for toward the end of April. We are using 3 databases because there isn't such a thing as a one wonderful database in our region, as you know, and we have to learn what that's all about and what next steps might be. So we've given these people a homework, which is to pick a disease or a condition that's of interest to them, poke around these 3 databases and see what they find in terms of services available. And we're using the at-home model, and we can't influence, nor should we influence, the healthcare side. So we've asked them to poke around the databases in 2 areas. One is community support available, and the other is social support available. And again, one of the big reasons for trying to adapt this MENDIT model is to tackle the subject of social isolation and loneliness. And so if we can find local community-led initiatives that people don't seem to know about, that's what we're all about. So once we get this, the feedback from these 12 people at the end of April, in terms of what they find, then hopefully we'll start learning about gaps. And over time, find citizens or community organizations that are help prepare, fill the gaps. But we're in the early stages of learning. And we are going to have a researcher come to that meeting so that we can capture the feedback from these people, and hopefully as we go along, keep it in a form that is, from a research point of view, viable for ongoing learning. So it's just finding individual projects that fit the model that help us realize ultimately these 2 goals, so that if you offer help to me, and hopefully I won't continue to say, no, thank you, I'm fine, even when I'm not. And then if I keep turning down help from you, as a community member, you'll lose interest or confidence in knowing how to help. And you'll say to me, let me know if there's anything I can do. And we know where that goes. It goes nowhere. It's like saying, Jim, we should have coffee sometime. So I hope that helps a bit.
Thank you, Florence. That was fantastic. And Jim, I know you have one more comment too. And a lot of the conversation, it seems, I mean, really, that's why DDQIC is here and initiating these panels, so that hopefully we can go back and they can come up with some solutions and ideas, so that we can be bringing that to the community, and then initiating some of those projects like you're talking about, Florence, and some of those opportunities. So Jim, keep going. We still have 15 minutes of open conversation and dialogue. So we're good for time right now. And so please go ahead, Jim, and then we'll await anybody else to comment.
That's good. And everybody else, please don't be shy. So David, the other piece I was now sort of envisaging, and it's my inclination because I just love interconnected things, is now the community connector hub, which is its own sort of, I think web, if you want, right? And not worldwide, but you know what I mean, web. Yep. And then how that then relates to the health home model, of the OHT. And so you can imagine that, there's a certain amount of alignment. Maybe the health home, part of the idea really there is finding strategically placed supports, where they can be the most impactful. But I'm just wondering, have you thought at all about how those 2 pieces might have synergies or interconnect or anything like that?
We certainly have on that one. Louise Moody's been on the call. I know the Compassionate Communities idea is part of the OHT's, here I am using acronyms and I apologize, but part of the Ontario Health Team's Aging Well at Home working group. So there is certainly a connection in there. I do know that, you know, the Ontario Health Team truly wants to change the way healthcare is delivered, and they know they have to start with the people or the person at the very center by their local community and support. So they are coming together.
Thanks, David. And Tracy, can I throw one more question to the audience?
Absolutely, yes.
So I mean, I was thinking about both what David was saying, but then Florence's comment too about, you know, finding people to, you know, sort of join in to the Compassionate Communities piece, the volunteers and others. Question for everybody, you know, are there lessons then to be learned? David talked about churches and service organizations. Are there insights to be gained by looking at other kinds of community engagement, you know, social events and groups that occur? I was thinking of things like, you know, sports teams, right? Or if you go, you know, at certain times of the summer, for example, if you go through Inverary, you'll see, you know, at the park and stuff like that, fish fries and things. But any of those kinds of pieces where people have come spontaneously out of some sort of shared interest, are there ideas or insights that we can gain from those that take place that maybe could provide some helpful insights into trying to build out, you know, compassionate community?
Anybody have any thoughts from the attendees? We're absolutely looking for your engagement. Bruna, do you want us to be doing anything with the results? What would you like?
Oh, and Helen has her hand up, Tracy, as well. So
great. Okay, so Helen, go ahead first, please.
Okay, I'd just like a general comment that, sorry, my phone just rang.
So while Helen's doing something there, I mean, Dan put in parent councils at local schools, for example.
And lake associations.
Lake associations, yeah.
Yes. Yeah. And then Bruna, did you want us to do anything with the results? No, nothing to comment on. Okay, no problem. Thank you. Any other thoughts? Any other comments? Any ideas? Nothing is not a good idea, please. We're looking to support as much as possible and give as much information as possible to DDQIC and Jim McClellan. Yeah, so let's go into those thoughts. There's good. Thank you, Bruna, for getting onto that. So why don't we ask some of these questions and maybe it'll trigger some thoughts as well. So what are the biggest challenges to innovation in rural KFLA health, Kingston, Frontenac, Lewiston, and health? You know, from an innovation standpoint, you know, we've heard that there's challenges obviously in broadband and high-speed internet. Is it lack of equipment, transportation? You know, we do have those top 5 key problems that we spoke about at the last panel. That's something to think if anybody wants to talk about that. I know that, David, we've asked this a couple of times sort of indirectly, what can rural residents and community members do to help, you know, steer this rural health innovation? I know we've asked that. Is there, at this point, you're thinking what, David, on that one? You're still kind of guiding through what's going on, right?
Yes.
And then I guess, you know, this is a good question, actually. How has the landscape for rural health changed in the past 10 years, or has it?
I would love to, well, Brandon's up there. He's from Sharpwood Lake. Let's have him jump.
Hi, Brandon. Please go ahead.
Hello. Sorry, specifically about you asked about barriers to innovation, and I would say staff turnover is huge, because often people get the job out here because nobody else wants it, and then as soon as they can, they jump ship to move to work in the city. So it's kind of hard to build a relationship with your healthcare providers if there's constantly a revolving door. Like, I think Sherwood Lake Family Health Team does a great job, but we've been through 4 nurse practitioners in the last 3 or 4 years. So it's like, it's hard to build that relationship. As for how it's changed, I mean, all the census, I think the census is generally pointing that, like, out in the rural area, people are getting older. And that's just what I remember. So it's like, people are getting older. It's harder for them to get around. And transportation is always a huge barrier.
Yeah. No, that's a good point. Aging population for sure is definitely a challenge, which of course then brings to light how important all of this is. I guess any other thoughts on some of those questions? And then, I don't know if there. Yeah, please go ahead. Sorry.
Well, no, Jay. I'm going to say Jay Turcott, so I don't know what the J stands for. So go for it.
It's Jackie.
Okay, Jackie. All right.
Hello. I just wanted to sort of add on Brandon's comment. Is that I grew up in the Northbrook area, actually. So I work there now as a case manager. I work for Addiction and Mental Health Services, KFLA, and I'm also on the board at Land O'Lakes Community Services. So not only is there turnover, but there's also funding cuts. So what I've experienced in my when I was just growing up there, and also in my professional life, is that there tends to be positions funded for full-time, and then the funding's removed or the program's cut completely. And I can honestly say that some of the rural communities are fickle. And it can cause when funding and supports are offered and then pulled away, and then offered and pulled away, there can be resentment that grows, and there's also distrust. And it can lead to reluctancy to accept services. Yeah. So that's a major problem, even that I'm dealing with, and I'm from that community. But I can kind of understand it because I've had sort of the personal experience with trying to advocate for myself, being a resident in those communities. So I think I'm overjoyed to hear that something like this is sort of in the works. I think that you sort of have to work from within the community to sort of heal the community, right? Like, so if it's community members helping community members, and with the support of community partners, I think I'm ecstatic about this pilot. I think it's going to be hugely beneficial to the rural communities. And I am going to go out there to everybody that I know and say that they need to show some interest, because I think this is long overdue. I think it's going to have such a positive impact on the residents, particularly when you get into the more northern regions of Frontenac and Lennox and Addington, like in, say, Denby, for instance. There's no cell service at all. There's nothing. And you just go into a complete dead zone. And it's unfortunate because not only, I mean, COVID caused a lot of isolation, but then you also have just isolation from not being able to get the supports that you so desperately need. So it just exacerbates that, the sense of loneliness and isolation, particularly for the elderly residents.
Yeah. Thank you, Jackie. That really important comments, and really and appreciate, because of my background in rural economic development, I really appreciate that the mistrust that happens, right? Because you get some resources, you get some funding, you get support, and then it's taken away depending on when the program timelines are. And absolutely agree. This has to be a longer term vision with sustainability. I just have a quick question. You had mentioned about physicians funded from a full-time perspective. So are you saying that there could be the part-time physicians, and then maybe have those physicians kind of move to different communities? Like, what are your thoughts on that?
Me?
Yeah.
Oh, okay.
Yeah.
I don't know. I know in Northbrook they have the family health team, and they've been there forever. There is a shortage of it. I think they're hiring for a doctor, but I think in my professional sort of perspective, I think that if there's the opportunity to have nurse practitioners to sort of aid in, because there's a lot of, even the clients that I deal with, there's so many people that are without a family doctor, and they can't, because of transportation, they can't get to walk-in clinics or go to the ER or whatever the case may be. And nobody wants to spend, 8 hours, 10 hours in an ER, or, lining up to be the first one in the door at a walk-in clinic. So I think not necessarily physicians, but I think getting nurse practitioners to get on board of maybe becoming available to people that don't have a family doctor, so that they're at least being seen in their own community. And maybe, because I know some of the community health centers that if you're on their wait list to get a doctor, you have access to their nurse practitioner, which I think is fabulous, because at least those people are getting some kind of medical care.
Yeah, absolutely. So I do have one question on that as well, maybe to David, and then the whole panel too, including you, Jackie, too, but everybody who's attending. So is there an education piece we have to consider for residents and community members on that a nurse practitioner actually is just as supportive and knowledgeable as a physician is? And is that an issue at all? Is that something I'm just, asking for no reason? Do communities feel that nurse practitioners are as effective? I know they are. We all know they are. But what is that perception from a resident standpoint? Is that something that has to be taken into consideration, David?
Tracy, it's a great question. I think, the difference from a nurse practitioner to a physician really comes down to somebody's own biases and information. So yeah, we need to understand, that if I'm dealing with a flu bug, a nurse practitioner can help me probably better than a physician could. And if I'm dealing with diabetes, I'm probably going to want to start with a physician and move into ongoing care in a more affordable way. So yes, there's education, but it's more just to me, a general understanding that healthcare is trying to figure out how to work together and make it cost effective to sustain it.
Yeah. Okay. Yeah. Because the education piece may be something to consider, Jim, while you guys are working together on the project. And then Alan Katz had mentioned, can rural community paramedicine play a role here? Alan, my apologies. I'm not sure if you were part of the first panel discussion, but we definitely talked a lot about that in the first panel. And, mobile units, paramedicine, getting access. Again, internet was a huge component to that solution where, can we have doctors working with patients and residents and communities to talk about needs and fulfill some of those challenges remotely, whether it's a mobile van, whether it's, whatever that looks like. There are definitely some things that the DDQSC team will be taking back and looking at in terms of solutions for some of those gaps and opportunities. And paramedicine and mobile medical support for our residents is really important to address. So I think we definitely need to keep that into consideration. Well, how are we doing? So I think we're kind of wrapping up a little bit. Is there any other last comments or questions from the attendees?
Brandon's got his hand up there, Tracy.
Brandon, go ahead, please.
Paramedicine, anything to reduce wait times, because it doesn't matter if you're seeing a doctor or nurse practitioner if you're sick today and their first opening is in June or July, right? Like, doesn't matter who you see if you're not going to see them for 3 months. Like,
that's very
so
good point.
Anything to reduce wait times would be much appreciated. If that's whatever it is, just like, it doesn't do anybody any good to sit waiting for a diagnosis for 3 months, and then what could have been maybe solved early with simple interventions is now a much bigger deal.
Yeah, absolutely. Good point. Nope, absolutely. And I think we all see a sense of urgency in this for sure. Well, I'm going to I'll do a little wrap up, and then I'll get the DDQSC team to wrap up as well. We really appreciate everybody being engaged and supporting the comments. We're going to go back with Queens to, look at some opportunities and do some deeper dives into what can we be doing to help support communities and all the community partners in health and rural health. And happy to be supporting this as well. So Jim, I'll let you kind of work on the next bit, and
Thanks, Tracy. Thank you, everybody. This has been really helpful, and we've been taking lots and lots of notes. to sort of go back to what I talked about at the start, which is our hope, DDQIC's hope, is to help sort of catalyze initiatives, support, how we can, but just reinforcing. And I think, the community, the compassionate community captures that. I think that the health home captures that, the sort of embedded groups and initiatives. And so this workshop was the second of a series, a dialogue, where it's mostly about listening and understanding, seeing what's out there, seeing the needs that are surfacing, seeing who's got some initiatives underway, identifying possible synergies or connections. The plan was then for the next step, start essentially sort of a mapping exercise of what's happening in the region. And in fact, actually, I think we're well on our way, right? I mean, the compassionate communities is an example where, I think it's really trying to connect more the distribution of resources that are out there and provide more resources, right? More sort of local nodes who can help people get connected. And so I guess two thoughts. One of them is, for a session that we might have, say, towards the end of April or maybe early May, if we can do it, what would be really nice would be to have at least one of the, an actual in-person location somewhere, I don't know, Central Frontenac, North Frontenac, South Frontenac, not Queen's Campus. Okay, get out of town, get out of the building. So if anybody has ideas of where those might be, okay, I don't know whether, community arena or something like that might be good, something that would allow, a bit of room, very informal. The other piece, though, is as we imagine what sort of initiatives either could be formed or grown, we need to really understand what's out there. And I think we've made great progress that way. But what I would say is I would like to put out for discussion and to hear what people think. But for the next session, what I think would be helpful would be to start by saying, okay, what's missing? Okay, and I don't mean, long detailed study inventory. I mean, it sounds like actually, thankfully, some of that's available. And I'd put that request out to the various groups that have been speaking. If you've got some databases and resources that could be shared just so people understand and so we're not duplicating work that's being done, I think that could be a first piece. So develop, sort of complete, if you want, a shared understanding of what's available and how it's happening now, a shared understanding of what initiatives are underway. So we're seeing compassionate communities and the OHT initiative, and then identify opportunities where we can build, where there may be other kinds of opportunities that could be formed, who'd like to get involved, and how can different people help. Okay, certainly from the standpoint of DDQIC, we can help in organizing, we can help in, small amounts of seed capital for initiatives. And I don't mean that to mean it's a private necessarily, right, without sort of prejudging what it might be, okay? We can help if people want some help in putting together sort of models and proposals, okay? We can help with getting connected, et cetera, et cetera, et cetera, et cetera. Okay, so, and as I say, it's not that we aren't interested in trying to do things ourselves, but what we're trying to do is to catalyze. Okay, I think the comment about the trust and the variability of funding, I think, is also a really important one to build on. And it suggests, are there then ways that we might raise funding, develop funding that might be more lasting? Okay, that would survive changes of, whether it's regional or provincial or federal for that. I mean, it's primarily health, so it's either regional or provincial, but, funding. But this theme has arisen, in some of the other stuff that we've been looking at with respect to food security as well. And so there's some increasingly innovative social funds, social investment initiatives as well. and so that might be another area that that could be helpful. Anyway, I've been rambling on. Long and the short of it is, really appreciate the input that we've had. Just really want to reinforce that we're trying to complement and build and grow from what's underway. And
Jim, I'm also wondering too, if we could consider doing a subcommittee just on the funding piece alone, and having the regional partners and maybe definitely the economic development offices out of each of the region, whether it's Lennox and Anton, Frontenac, Kingston, even Leeds and Grenville. Happy to initiate a subcommittee on the funding piece and work with Queens on what that funding could look like provincially or locally. If everybody, I think there's definitely an interest in that. And then we could then maybe look at some projects that all of you guys are doing, and David and your team and everybody that's attending. And I think there could be some good collaboration.
That sounds great. Thanks, Tracy. I mean, the piece I'd throw out in addition to that would be, maybe we could reach out to Joan Reynolds, who's been helping out with the food, and with Keshav, who's been helping with Social Venture Fund. Just to see, we've seen some really interesting work that's been taking place elsewhere related to food security, food provision.
Okay. No, that's great.
And so I can't help thinking that there may be, and of course that always touches on that delicate question of public, private, and everything else.
Mm-hmm.
But it'd be good to get out there and say what sort of novel, community bonds, patient capital, what sort of novel newer generation investment models might there be that could also then be a piece for this.
Yeah, no, absolutely. No, good point. Bruna, did you have any last comments?
No, I believe Jim covered everything. We just wanted to say thank you to everyone that attended, to David and Tracy for moderating and speaking, and to the entire DDQIC team. And I know I messaged some people individually, but if you've been on this call and we haven't had a chance to chat and you'd like to share your perspective, please reach out to us. I believe Megan just put a link in the chat. We really just want to try to get more one-on-one conversations going, and try to get to know all the different perspectives that are out there. And we will be posting this session that was recorded soon, and we'll also be posting about a follow-up session shortly as well, as Jim mentioned, probably in late April. So thank you very much, everyone, and I hope you all have a great day. And I think Jim has something else.
One last comment. Feedback welcome, please. Okay, so feedback in terms of the mechanics of how this is evolving, how we're doing. Okay, is it too slow? Is it too fast? Are we missing things? Et cetera, et cetera, et cetera. Because this is a learning process for us. We want this to be impactful for you. That's the single biggest reason we're doing this. And so please don't hesitate. Please don't be shy. We're trying not to go too quickly, but we want to make sure that you feel that this is actually moving possibly to some initiatives, as opposed to just yet more talking or something like that.
Thanks, Jim.
Thank you.
And thank you, David, as well, for your time and for everybody and being engaged today. We really appreciate it. Have a good afternoon, everyone.